piriformis, and then that will be the 4, I think there's only 4 MLTs for this and the second one, and that will be it. Okay, can you straighten your legs out for me? So, I'll show you this side. The first thing you want to do, patient supine, you want to check underneath their backs to make sure that they don't have excessive lumbar lordosis. And what I mean by excessive is if I slide my hand underneath their back and I'm not touching, like if my hand's touching the table and it's not touching their back because it's so lordotic, that's excessive lumbar lordosis. Does that make sense? So if that were the case, what you could do, if I'm testing the left side, again, clinically, I would be testing the side closest to me. I'm going to show you the side closest to you so that you can see it. But so if I'm testing the left side, what I could do is roll up a towel and put it underneath the contralateral side, just kind of on that ischial tuberosity. I'm going to take it out. He's already got good positioning. I don't actually want to put him into any more posterior pelvic tilt, but you'd be putting it underneath the contralateral side to try and get some posterior pelvic tilt from the contralateral side. Does that make sense? Okay, you can go. So I don't need to do that in this case, but checking to make sure there's no excessive lumbar lordosis first, adding that towel roll on the contralateral side from the testing side, just to fix that if needed be. And I forgot a gunny. Can I borrow this gunny? Thank you. So this, as long as you want to make sure your patient doesn't have any knee injuries, because you're going to be keeping the legs straight and they're going to be kind of hanging out on the posterior knee ligaments. So you want to make sure that there's no injury or rehab that can cause further damage. But this is actually fairly straightforward. You're just going to lift that leg until you feel that first muscular resistance. Normal would be 80 degrees from the table, or are we doing from pelvis? Like from midline of the pelvis. So 80 degrees from the table here, or are we using mid-pelvis?
I would say
Pelvis. Okay, so 80 degrees of hip flexion. You're going to use that greater trochanter, midline of the pelvis, along the femoral, lateral femur, toward that lateral femoral epicondyle as your landmarks. Making sure you want to keep the knee straight because this is a muscle length test for hamstrings. So if the knee starts to bend, then that's because hamstrings are tight. So keeping that leg straight, also making sure that you're not getting some crazy abduction, external rotation, any other kind of weird compensations. And I'm just going to keep hand on the pelvis. Table is really going to be doing most of the stabilization, but I just want to make sure I'm palpating that pelvis so that I'm not getting a whole lot of posterior pelvic tilt, because then where do the hamstrings attach?
Ischial
tuberosity. So if he's posteriorly pelvic tilting, then the hamstrings are going to get extra range. Does that make sense to everybody?
Yeah.
Okay. So telling him nice, easy breathing, relax, and I'm feeling first resistance here. To me, that looks like it's about 45 degrees, so there is definitely some tightness going on.
did a lot yesterday.
Wait, sorry. This is where it matters that you're using the right numbers.
Fulcrum is a greater trochanter.
Fulcrum's greater trochanter, yes. And you can actually ask, especially when you're looking at big appendages like the legs, you can have the patient hold the gonine when you get it positioned. Okay, can you hold it there? And then that's where I'm going to be able to come down and make sure I'm not moving, and he's actually at 42.
And it's 80 degrees.
80 is normal. So